students. I'm a physiology faculty from DBMCI, and as we know that DBMCI is creating a wonderful sessions for you guys. So today we came up with the clinical integrated questions of physiology, right? Without wasting any further time, let's start off with the questions. The first question over here is: a 32-year female came with a dehydration and history of syncope. While giving the corrective measures, an addition of 500 ml of hypertonic saline is given to her. So what is the clue? 500 ml hypertonic saline is given to her. This error will lead to. And with this question, there is a diagram shown over here, and from there you do have these options in the format of the diagram, and then you have to choose from all of this option. Now, for this particular diagram and this particular concept, this diagram is not even given, it is not given in the so-called Bible of the physiology, that is the Canon. Okay, so you have to refer to the guidance or the notes, right? So this diagram is known as Darrow-Yanet diagram. So this diagram is known as Darrow-Yanet diagram. Now, what is this diagram is all about? This is nothing but you do have two axes. So this is kind of a graph, but given in a rectangular form. Okay, so you do have two axes, x-axis and y-axis. On the x-axis, what we are giving over here is the you can say the volume changes will be given on the x-axis, right? And the osmolarity changes are given on the y-axis. So this is just the volume per se and the osmolarity changes that you have to check what is going to happen if you given some fluid or if some fluid is lost from the body. Okay, so particularly two things you have to keep in the mind. First is the volume, second is the osmolarity whenever we discuss about this Darrow-Yanet diagram. Now, either you can take osmolarity or you can take osmolality. Now, what is the difference between osmolarity and what is the difference and how it is different from the osmolality, right? So osmolarity or osmolality. Now remember, when I say this, I always give the hints that when you get so confusing, so nearby similar words, you have to make something to remember forever, right? So there are tricks to remember. And what is the trick over here? That when we do have two L's, we do not want any more L. Okay, only two L's can be suffice to follow our trick. So any more L will not be compensated over here. So we say that when we talk in terms of solutes, per kg of the solvent, when we use per kg, then we choose the osmolality. And as I told you that L will not go with L, that means if we take in terms of solution, so the osmoles, that means the solutes or osmoles, we can say them as osmoles present per liter of solution. I'm not saying solvent, I'm saying solution, right? So if you take per liter of the solution, so look over here, this is liter, so that's why this L will be extra, right? So we say that L will not go with L. So only one L is there. When we talk about osmolarity, we talk in terms of liter. When we talk about osmolality, then we talk in terms of kg of solvent, right? So it doesn't matter in the Darrow-Yanet diagram because these are the similar ones only, right? So you take either osmolarity or osmolality, it is one and the same, right? The thing is over here, you have to check whether it is going to increase or decrease, right? So let's see one by one. So I have a diagram for you guys to make it easier to understand, right? So whenever we talk about, see, in the first diagram, what they have shown over here is that whenever there are two compartments. As we already know that there are two compartments. When we learn the total body water also, then we learn that there are two compartments, ICF and ECF, right? So whenever we talk in terms of volume, we are going to talk in terms of these two different compartments. And this dotted line is showing what are the changes happening over here, right? So if the osmolarity is increased, then this line is going to increase. That means which is the parallel to the volume line. Okay, don't confuse with that. And if the volume changes occurs, obviously it is going to show like this or this. Okay, either it is decrease, increase, whatever it is. Now, one rule to remember in Darrow inlet diagram is that osmolarity or osmolarity, it is never going to be different in the two compartments. It's always same in both the compartments. It always same because it is maintained. It is one of the physiological, you can say, parameter that is well regulated in the body. That means it is well regulated throughout the body. So wherever you are going to talk about the osmolarity, it will be the same, always same in both compartment. So in one, if say suppose ECF may you increase the osmolarity, in ICF also it is going to increase. If you decrease in one compartment, another compartment compensate for that, and that also either get decreased or add some volume in it or the salts in it, and then it is going to increase, right? So always the osmolarity and the y-axis is always same in both. That you have to learn of, right? Now let's see one by one. Or isoosmotic. Now we are going to learn in two cases. If there is a volume contraction, that means either the volume is lost from the body, right? Then what is going to happen? And volume expansion. That means if the water is gained, water is lost, water is gained, that's the whole play is about. Okay, the thing is how the water is, that means it's isoosmotic. That means the osmolarity of the water is similar to the plasma, or it is hypoosmotic. That means the osmolarity of the water is less than the plasma, or hyperosmotic. That means the osmolarity of the water is higher than the plasma. Okay, so simple easy terms, right? So let's talk one by one. When there is a diarrhea, so when we talking about the isoosmotic, whenever we are going to talk about the isoosmotic or isotonic, right? Tonicity is nothing but the osmolarity. The same word we can use. If the isotonic solution is there, then what is going to happen? So whenever you are going to either add or subtract, or you can just say volume contraction of the isotonic solution is going to happen, then only the changes will occur in the ECF. Only changes are going to occur in the ECF because the osmolarity is not changing over here. So that's why only volume change will occur, and that is going to occur in the ECF only. Okay, so whenever we talk in terms of ISO, we are only going to change one property, that is the volume, and that too in a one compartment, that is the ECF, right? ECF. Now, if for example diarrhea, the option, you can say example is given over here. If somebody has diarrhea, then what is going to happen? He's going to lose the isotonic or isoosmotic water. Now you can see that from the ECF he is going to lose the volume. So that's why the volume contraction occurs in the ECF, but the osmolarity is not going to change since it is the isoosmotic loss. Okay, now the second thing, if you add the isoosmotic, that means 0.9% of NaCl solution, right? If you are going to add that, what is going to happen? What is going to happen? First thing, isotonic fluid is added to the ECF. Whenever we add, obviously we do not add it in the cell, we add it in the plasma, right? So intravenous, and the plasma volume is going one of the part of the ECF, except this interstitial fluid, right? So both are the part of the ECF. So whenever we are going to add something, we are going to add it in the ECF. So if you add something in the ECF, what is going to happen to the volume? The volume is going to increase. The volume is going to increase, and the volume is only increase of that of the ECF. No change will occur in the ICF since the tonicity is same, right? Then let's move on to the hyperosmotic. Hyperosmotic. Whenever let's say water deprivation, that means we do the volume contraction, that means volume loss is there, then what is going to happen in the different volumes? Hyperosmotic. And that too, that means we are losing the solutes. We are losing the solutes. We have the water inside the body, but we are losing the solutes. So whenever Whenever we are going to lose the solutes, obviously the osmolarity is going to decrease, right? So hyperosmotic, that means we are losing the see, hypoosmotic fluid is lost. Okay. Over here, what they're talking about, that hypoosmolar changes that are talked over here. Hypoosmolar. So they are talking about hypoosmotic fluid is lost. Okay. So reverse condition is given over here. If you lost water, then what is going to happen? If we lost water, then what is going to happen? Obviously, the osmolarity will increase. The reverse condition is given over here. That is, condition they shown is hyperosmotic, not the hyperosmotic loss. Okay, so opposite thing is given over here. So condition is going to be hyperosmotic. Why? Now look over here, we are losing the water. We are losing the water, and which water? Hypoosmotic. That means we are just losing the water, right? Not the solutes. Solutes are still there, but we are losing the water. If solutes are there and losing the water, that means per kg or per liter, the osmolarity will increase. Osmolarity, that is going to increase. So obviously the osmolarity is increased and volume is going to go down. Okay, volume loss will be there. Don't worry, I'll make you write the table, which will make the things easier, right? Just concentrate over here for some time. High NaCl intake. If somebody had a salt, a very large amount of intake of ingestion of salt, then what is going to happen? He is not drinking the water over here, but he ate a lot of salt. Then what is going to happen? First thing is, in this, as soon as he ate the a lot of salt, what is going to happen? That is going to go and get absorbed into the blood, and that's why the osmolarity is going to increase in the ECF. But I told you that both ICF and ECF, they maintain their osmolarity level. So to maintain the osmolarity, when it is low in the ICF and it is higher in the ECF, what happens is, from the ICF, the volume or the water is going to move into the ECF. Now what happened? It tried to compensate for the osmolarity, try to compensate the volume. Okay, so what is going to happen in the ECF? See, in the ECF the volume is going to increase, but since the ICF compensated that volume, that's why the volume is going to decrease in the ICF. So ICF volume is decreasing, ECF volume is increasing, and since he ate a lot of salt, so that's why obviously it's a hypertonic condition, and that's why what is going to happen over here is that there is increase in the osmolarity. Okay, then let's learn some hypoosmotic condition also. So there is an adrenal insufficiency. One of the example, adrenal insufficiency. So what is going to happen if there is an adrenal insufficiency? So see, hyperosmotic fluid is lost. Now they're saying hyperosmotic fluid is lost. That means suppose that the salt is lost. Okay, the salt is adrenal insufficiency mein, there is no release of the mineralocorticoid which are going to absorb the salt, right? So if the mineralocorticoid secretion is not there in the such as Addison disease, right? So what is going to happen? Obviously the salt is not getting absorbed. So what is going to happen to the first thing? What is going to happen to the osmolarity? It is going to decrease. It is going to decrease, right? And the second thing is, we want to maintain the osmolarity. So what is going to happen is that first thing, ECF is going to lose the you can say water, and since the osmolarity is decreased, ECF may, if there is a low, you can say, what to say, if I told you that osmolarity should be maintained in both, and if you're losing the salt but not the water, so what is going to happen? The water will be higher in the ECF. So water should be going somewhere, right, to maintain that osmolarity. So it moves into the ICF, and ICF volume increases and ECF volume decreases. Exact opposite condition that of this high NaCl intake. NaCl intake कर लिया, if there is an intake, then ICF volume, the volume graph will shift towards the right, and if NaCl, the osmolarity is lost, then the graph will shift towards the left. Okay, now let's talk about the another last condition, that is SIADH. Water is added. What is happening in the SIADH? What is SIADH? First of all, it is a syndrome of inappropriate ADH secretion. So what is going to happen in that? ADH secretion will be very, very excessive. So if the SIADH is there and ADH secretion is a lot antidiuretic, it is antidiuretic. That means it is going to increase the volume via absorbing more and more water, right? Via its V2 receptor, it is going to produce more and more aquaporin 2 channels, right? It is going to get inserted into the distal tubule and going to absorb more and more water. If more water is absorbed, what is going to the volume? What is going to happen to the volume? It is increasing in both of these compartments, ICF as well as ECF. Now, if you talk about the osmol number, either per kg or per liter, over here we are talking about osmolarity. So I'm going to talk in terms of per kg, right? So osmolarity is going to decrease. Why? Because the osmol, because we are taking more water, but we are not taking that much amount of salt, obviously the osmolarity relatively is going to go down. So you can see over here that osmolarity is decreased. The osmolarity is decreased, right? So let's talk about the isotonic. I'm going to write over here the tonicity, isotonic fluids, right? If there is an addition or loss of this isotonic fluid, then what is going to happen? And to whom it is going to happen? That is, first of all, we are going to write ECF volume. Obviously, whenever the changes occurs in the volume, that starts from the ECF, then ICF volume and the osmolarity. Okay, what is going to happen to them? Okay, so let's talk one by one. If isotonic fluid is there, and if you add the isotonic fluid, what I told you, isotonic, that means the osmolarity will be having no change, right? And ICF volume will be having no change. So what is going to happen? If you add, the ECF volume is going to get more, and if you extract or you do the contraction of this isotonic fluid or isotonic fluid loss occur, what is going to happen? The ECF volume is going to decrease. ECF volume is going to decrease. The next thing we are going to talk about is hypotonic addition or loss. Hypotonic gain or loss, or addition of loss, one and the same thing. Addition or loss, gain or loss. Now what is going to happen to the ECF volume? Remember, if you gain hypotonic fluid, obviously the volume is going to increase because there is no salt in it, right? So first effect will be on the volume, that is volume is going to increase. If loss is there, it is going to decrease, obvious thing. Then similar changes will occur in the ICF also. So ICF volume is going to increase and decrease in the gain and loss respectively. Now, if you're adding the water and not the salt, the osmolarity will have reverse effect. That means it is going to decrease. The diluted solution will be there, and that is going to decrease. And in this case also, reverse is going to happen, that if you lose the hypotonic solution or the water, the osmolarity is going to increase, right? We just now saw the conditions such as SIADH, right? Or drinking tap water. There is one question that was asked in 2 years in the AIMS, 2 years before in the AIMS, that marathon runner, he was going somewhere, and after the marathon he drank a lot of water without any salt. So electrolytes changes, right? Tap water is not going to contain any much of the electrolyte, or the distilled water is also not going to contain any you can say minerals. So that's why this change is going to happen. Okay, so drinking tap water is also come under the gain of the hypotonic solution. Let's see the third condition, hypertonic solution. Hypertonic solution. In this also we are going to make a chart of gain and loss, in gain and loss. So if you get hypertonic solution, so what is going to happen to the ECF volume? It is going to increase. Remember, it is going to increase, right? And what is going to happen to the ICF? It is going to decrease. Why? Because the ICF volume itself is coming into the ECF, because we are not adding the water per se, we are adding the solutes, right? The opposite thing is going to happen in this. Opposite thing, whenever there is a loss of this hypertonic solution occur, so opposite thing is going to happen over here. Now what is going to happen to if you add the hypertonic, obviously the osmolarity is increase. If there is a loss of hypertonic, osmolarity is going to decrease. And the gain condition, any example? Yes, NaCl intake or uptake, right? And there is, if adrenocortical insufficiency. Okay, so these are the examples of this, and this is the chart of the Darrow diagram that you need to remember, right? So let's go back to the question and let's see that what they want us to talk about. Okay, so over here, see, addition of 500 ml of hypertonic saline, addition of hypertonic saline. Okay, so addition, that means gain of hypertonic. What is going to happen to the diagram? These changes will be there. Let's spot out where are those changes are present. So hypertonic may, we just now talked, if there is a gain in the hypertonic, first thing is we know that osmolarity is going to increase. First thing, obviously you are adding the salt. So what is going to happen? You are adding the osmoles. Obviously the osmolality is going to increase. So definitely over here in the D option, only this is the option which is, I can see over here that there are increase in the osmolarity. It's a very easy to make out, right? Go with the osmolarity first. If you are adding the hypertonic, that means you are adding the osmoles. So definitely answer is this. Let's counter check it. Obviously, if there is increase in the osmolarity in the ECF, I told you that ECF will show the first changes. So definitely ICF volume will shift into the ECF, and that's why volume contraction in ICF and increase in the volume in the ECF will be seen. So this is the correct option, right? So answer over here of this question is option D. If you know the concept, right, of this Darrow diagram and osmolarity and volume, you can easily sort it out. Very, very easy. In a first go, you will get to know as soon as you look at the osmolarity. Okay, let's move on. Let's move on to the second question. Second question is telling us about the 56-year-old woman presented with a flat red rash on the face, upper trunk, erythematous rash on the knuckles and shape V. Basically SLE lesions are there, and neck, anterior chest, okay, complaint of weakness, difficulty getting out on the chair, combing her hair, right, includes positive ANA and anti-MI2, dermatomyositis. ANA is anti-nuclear antibody, right, and okay, okay, then she is on prednisolone, right, and therapy, okay, fine. Now they are saying that once she started on this, that is the corticosteroid, that is autoimmune disease that we are dealing with over here. So when she started the physical therapy, she is improving her muscle strength, thus ability to perform the activities of daily living, repetitive. The question is hiding in the last line itself, because yes, I know the question already. So whenever you are approaching such a long question, first read the last line. You may not know that, you even don't want to read that story. There is no need of that reading those stories. So what the last line is saying, repetitive and prolonged stimulation of skeletal muscle fiber. So continuous and prolonged stimulation we are giving muscle fiber will cause in the increase in the contractile strength due to increase in which of the following. Okay, so what increase makes increase in the contractile strength, that we need to talk about. First they're asking about cross bridge cycling, concentration of sodium. Now sodium in the myoplasm is not going to increase, there is increase in the calcium. Sodium causes, remember there are two different phenomena. When we talk in terms of any electro or neurophysiology, nerve muscle physiology specifically, then what we talk in terms of that there is an electrical phenomena that we call it as either RMP or action potential, right, which is going to get followed by, yes please, mechanical phenomena, right? And mechanical phenomena, that is nothing but the response that is going to given via this to this electrical phenomena. That is usually when we talk about nerve muscle physiology, we talk in terms of contraction, right? So this over here is what they're asking is contractile strength. That means they're asking about the mechanical phenomena over here, right? So the sodium, if it increases in myoplasm, that is going to lead to the electrical phenomena, but that has nothing to do with the strength. Okay, that is just all or none phenomena. Electrical action potential is always all or none phenomena, right? And if you increase the sodium concentration slowly, that will rather decrease the you can say the action potential, you can say the sensitivity. Okay, so you have to give higher threshold. So that's the problem with that. The magnitude of end plate potential. Again, the end plate potential, once it is going to reach to the firing level, then only we are going to get the action potential. And once we get the action potential, then only we are going to get the contraction. If we are talking about the end plate potential, EPPs are very, very, small potentials. They are also, there's the small potential. They are not action potential, right? They're the local potentials which are going to get present, or end plate potential are the ones after releasing one vesicle. In that, whatever amount of neurotransmitter is present, whatever amount of local potential it is giving, that is nothing but end plate potential. And as I told you already, the action potential or the electrical phenomena has nothing to do with the strength when we talk about, right? So this is also cannot be the answer. The number of muscle myofibril generating tension. Now over here they're talking about the number of muscle myofibril. So yes, they're talking about the mechanical phenomena. So first thing we got to know that yes, 50-50 option, that these two are not the options, right? So duration of the cross bridge cycling or the number of the muscle myofibrils. Now look over here, what they ask about us, what they told in the, what is the hint? Now we cause repetitive as well as prolonged stimulation of skeletal muscle. So if you do repetitive and prolonged stimulation, obviously the maximum number of muscle fibrils are going to get activated, right? So there is no chance of increasing the number of muscle myofibril. Yes, if that would have been the case in the the successive stimuli when we talk about, but this is not the case. We are prolonging the contraction and also we are doing it repeatedly. So whatever maximum numbers of myofibrils are there, they are going to get activated. So no more you can say myofibrils are going to generate the tension. Whatever amount is present, obviously the number of muscle myofibrils, all of them are going to get activated. So finally the answer over here is option A. I wanted to show you some diagram regarding this, so that to make this concept also very, very clear. So how this cross bridge formation or the muscle contraction occur. Look, in this we do have contractile protein. When we talk about contraction, always and always we think about actin and myosin. So these green fibers, the globular fibers, which are the globular, you can say, chains which are forming this one filamentous chain, that is the actin fibers, right? And over here, which are the thicker fibers, they are the myosin fibers. So whole of this is the myosin, and these upward are the head of the myosin. Okay, so there is a head and tail of the myosin, they are the two parts present. So what happens is, not only these two are going to cause the contraction, because as I say in the you can say to the children who I teach, or the students who I teach, I told them that suppose these actin and the myosin, the actin is as a girlfriend and the myosin is as a boyfriend. The problem is they cannot meet because of the daddy of this girlfriend is coming in between. And who is that daddy? That is tropomyosin. Okay, and he hate myosin, so he will not allow the myosin to come, right? So he is standing in the door, that is the active site of actin filament. So she cannot meet the myosin. Okay, so what is going to happen? We need some friend of this actin who can divert the concentration of this tropomyosin for some time, and then the actin myosin can meet and the cross bridge formation will occur and the contraction will take place. Simple story, right? So who is that friend? Troponin. But troponin also alone cannot handle this tropomyosin, so we require the calcium. So what happens is, as soon as the depolarization occurs, that depolarization will lead to opening of the calcium channel. So first of all, we require the action potential, which is going to cause the depolarization. That is the first phase of this action potential, right? That will lead to opening of calcium channel. As soon as this calcium channel is going to open, that is going to bind with this troponin. As soon as this combination occurs, the tropomyosin will move from that site. It will move from the active site of actin filament, and then the active site of actin filament can meet with the myosin head, right? So the this is known as cross bridge formation. This is known as cross bridge formation, and that happens whenever this is in 90 degree of angle. This is possible whenever this is in 90 degree of angle. And then what happens is the ADP and PI, they are going to get released. I'll talk about that. As soon as they release the inorganic phosphate, as it releases from this myosin head, it creates the you can say the stroke and power stroke, and that will lead to the cocking. We say the bending. This myosin head will bend, and that is known as cocking of the head of this myosin. Okay, so that will going to bend, and since it is bound to this actin, during the bending, what is going to happen, it will take the actin myosin with it. It will feel as if, when we look at it in the microscope, it will feel as if the actin fiber is sliding on this myosin. It is sliding on this myosin. So that's why this contraction process is known as sliding filament theory. This is known as sliding filament theory. Easy, right? So that I was talking about over here, because they asked the INI-CET, this was the question came that what is the angle of it. So remember, this is the first phase. What is going to happen whenever this all this action potential and calcium thing is going on? First thing which happens is, as soon as this ATP, similarly when the depolarization is taking place, there is a ATP molecules available. Obviously this is an active you can say process, so we require the ATP. So whenever the ATP is going to bind to this head of the myosin is relaxing, right? He is relaxing his 45-degree angle. He is waiting for the signal. And what is the signal? ATP will come and wake this myosin up. It is going to wake this myosin up. As soon as it is going to wake this myosin, but what happens as soon as it binds to this myosin filament, this head of this myosin filament has a specific activity which is known as ATPase activity, Whenever there is a A's coming in the word, that means it is breaking down something. Breaking down what? Whatever the prefix is there. That means it is breaking down the ATP. So the ATP is going to get break down into ADP and PI, that is an inorganic phosphate. As soon as this activity occurs, this relaxed myosin will become alert, very, very alert, right? So it causes the 90-degree angle. So he was sleeping. First of all, he will wake up due to this ATPase activity. Once the ATPase broke down this ATP into ADP and PI, right? 90-degree angle. Right? Then what is going to happen, as soon as the calcium is going to get released from the sarcoplasmic reticulum, this calcium will do all those things which we just now talked about, right? And that's how the active site of actin filament will be open, and the myosin will bound to it already, because it was in the 90-degree angle. So it is very, very easier. So once this process occurs, it bound to the active site of actin filament. Then what is going to happen? There will be the release of this PI and ADP. Okay, ADP and PI do not like the myosin meeting with the actin, right? They get upset and they release from him. They will leave the myosin. Okay, as soon as they will leave, there is something known as power stroke occur, right? This you can say myosin fiber start getting upset that PI and ADP left the myosin. So what it does, he start going into the passive process again, right? That means the cocking process. That means he is going to bend his head as it was in the previous you can say scenario when he was resting. Okay, so what is going to happen, the 45-degree will take place, but during doing that, this actin he will take the actin myosin and then he go in the relaxation. So this is known as the sliding filament theory. Okay, so we already talked about the answer of this question. This question answer is because of the cross bridge cycling. Okay, so duration of the cross bridge cycling, it actually increases. What happens is, whenever you say that why this duration increases because there is a pump known as Circa pump. Suppose this is a sarcoplasmic reticulum. In that, there is a pump which is known as Circa pump, which or you can simply say calcium ATPase. Calcium ATPase. What it does is that it sends the calcium back into the sarcoplasmic reticulum. But when you give repeated prolonged stimulation, what happens is the ATP will be finished, and once the ATP is over, this pump cannot act anymore and the calcium will retain inside the sarcoplasmic reticulum. So the concentration of calcium will increase, but ultimately what it is increasing? Ultimately the duration of the cross bridge cycling, it is increasing. So that's why the answer over here is option A. Let's move on to the next question. Next question is question number 3. A 35-year-old woman is seen by neurologists to evaluate her incapacitating muscle weakness. Neurologists suspect. So first of all, we'll start with the end, you can say sentence. Which of the following most likely explain the ability of drug? So there is some drug which is acting on the disease to increase the force of muscle contraction in the patient with the myasthenia gravis. So you do not need to even look at the story, what they are telling, right? But still we do have time right now, which it is not as precious as the exam, so we do have more time than the exam, so which you get in the exam. Okay, so the neurologist suspect myasthenia gravis. So it is given the to confirm his diagnosis and administration of the drug that increases the force of contraction of the muscle. Obviously muscle contraction in the patient of the myasthenia gravis is given. Caution that the patient is having the heart disease, so he gave the caution of bradycardia may develop by this. So definitely he is giving the drug which inhibits the acetylcholine esterases. Acetylcholine esterases, since we know that if the bradycardia, he is talking about bradycardia. So acetylcholine is going to be a parasympathetic stimulator for the nodal tissues, right? And if the parasympathetic stimulation occurs to the nodal tissue, what is going to happen to the pacemaker potential that we are going to talk about? The pacemaker potential, the slope decreases and the heart rate comes down. Just remember, cholinergic activation, the heart rate comes down, which we call it as negative inotropic effect. Negative inotropic effect, that we are going to talk about the pacemaker potential later on. Okay, when we are going to talk in terms of the CVS question. This is the neurology question. So what they are asking, what is that drug or how it is acting, right? So the drug increasing what thing so as to do this effect, right? So let's go one by one. First is increasing the amount of acetylcholine released by the motor neuron. See, myasthenia gravis is not the problem in the release of the acetylcholine. It is the antibodies, autoimmune disease. So the antibodies blocking the receptors. So they are sitting where the acetylcholine should sit, right? So obviously there is no problem in the amount of acetylcholine it is there, but the problem is they are blocking the you can say the receptors. So this cannot be the answer. Increasing the affinity to skeletal muscle acetylcholine receptor to acetylcholine. So if that affinity increases, then there is no such drug that directly act on this affinity of skeletal muscle acetylcholine receptor to acetylcholine. Obviously this is going to be blocked via the autoimmune you can say antibodies. So what we can do is we'll see later on, but this cannot be the answer. The affinity is not increased, there is no such drug, right? Increasing the motor neuron discharge rate, if the receptor is blocked, obviously the motor neuron discharge rate is not going to be increased by itself magically, right? We are not living in a fantasy world. So decreasing the metabolic breakdown rate of the acetylcholine. Yes, this is possible. Yes, this is possible. So answer over here is option D. Why I'm saying so? Let's see that. Okay. Myasthenia gravis, when we talk about, we talk in terms of when we talk about, we talk in terms of the acetylcholine release and the antibodies. Now you can see that acetyl CoA and the the choline and acetyl CoA, they will combine to form the acetylcholine. Then the vesicular formation will occur, and they will be accumulated in the vesicle, so that whenever there is a need, this store can get exocytosed and the release will take place. As soon as this red color dots are showing the action potential, as soon as this action potential is coming, what is happening over here, they are going to cause the depolarization. Depolarization will also open the calcium channel. Calcium channel, once it is going to get open up, there are something known as snare proteins, which we don't have much time to discuss. We already discussed in many lectures, right? So this snare protein with the calcium, they the snare protein and the calcium, they will pull the vesicle towards its presynaptic membrane, that is this membrane, and the exocytosis will happen. So for the exocytosis, the calcium is at most important, right? And once the exocytosis occur, what is going to happen is, as soon as it acts on the receptor, then its breakdown is going to take place via an enzyme which is known as acetylcholine esterase. Acetylcholine esterases. If we use the drug which can block this acetylcholine esterase, if we use the drug which blocks this acetylcholine esterase, the amount which is present in the synaptic cleft, the amount which is present in the synaptic cleft is going to increase. I'm not saying that increased amount is going to get secreted. The amount in the synaptic cleft is increased via this process, and there is something known as competitive inhibition will occur. Competitive inhibition, which were occurring because of this antibodies that will overcome via this, right? The acetylcholine is going to get increased via this, you can say, the stimulation, right? So if they increase, this is kind of a musical chair, you can remember, for if you have less chair and more people to sit, whomsoever in front of that, that is going to win the race, right? Over here, whomsoever is more in the concentration, that is going to increase the, or that is going to win over here to sit on that particular receptor. So we basically decreasing the breakdown and increasing its concentration in the synaptic cleft, and so as to increase those concentration and have the effect of the acetylcholine. And this acetylcholine will have the effect, and that is going to recover the patient from its symptom, right? If you are talking about the first option, released by the motor neuron, if you have to increase the release by the motor neuron, you have to give more frequencies of action potential. Any drug cannot do that. So action potential, we are not working over here, we are working on the acetylcholine esterases. So answer over here is option D. Answer over here is option D. Let's move on to the question number 4. Question number 4 is asking, a 10-year-old girl with type 1 diabetes developed neuropathy limited to sensory neurons with a free nerve ending. So over here they're asking free nerve endings. That is a clue. Quantitative sensory testing will reveal higher than the normal threshold for detection of which of the following. So two things we have to take care of. First is the free nerve endings. Second is higher than the threshold, normal threshold, that is going to cause detection of what thing. First thing, if you even know that what this free nerve endings are talked about, or all other things, fine touch, vibration, pressure and temperature. So these are the somatosensory, you can say, sensations, right? So when we talk about that, we should know about the somatosensory receptors also. So look over here, these are the somatosensory receptors. These are the somatosensory receptors. First of all, you should know that suppose this is the dermis layer and this is the epidermis. So above layer is epidermis, and this downward is deep layer is dermis. So you can see in the epidermis you do have the wale corpuscles or receptor, that is Merkel's disc and Meissner's disc. Both are going to help in the touch sensation as well as 2-point discrimination. This question is many a times asked, that who is better in the 2-point discrimination. The answer over here is Merkel cysts because they do have small receptive field, and that's why they are going to win this race of 2 point discrimination. So if there is no option present as a Merkel's disk, then if Merkel's disk is not in the option, then you can go for the measles corpuscles. Both are going to use for the 2 point discrimination. It's just that the Merkel's disk is a lot better than the measles, right? Then we have Ruffini endings, which are the mechanoreceptors, which sense the stretch, as well as some books write that it is also sensing the temperature. So stretch and temperature. Then we have Krasberg end bulbs. They are going to feel or sense the cold temperature. Then we have Pacinian corpuscles. P for P, remember, P for Pacinian, and we talk about P, so pressure. B for pressure. So we are done with this temperature thing. Now there are free nerve endings which are not shown over here. So free nerve endings. So see over here, everything is having the capsule like covering. Okay, everything is having a capsule like covering. They are not the free nerve endings, right? So you can see that these are the nerve endings which are encapsulated, well encapsulated. But there are some nerve endings which will be free, right? So there will be free nerve endings, and what they sense, remember the free nerve endings, they are going to sense what thing? Yes please, they are going to sense the pain sensation. So even if you know that free nerve ending sense the pain sensation, then definitely you will go with the pain sensation. But pain sensation is not there in the option. So what is the another clue? Higher than the normal threshold. So remember, when we talk about higher than the normal threshold, all of this are not going to cause the pain. But yes, this is proven via the research that if you increase the temperature, so if you increase the temperature till 42 degrees, it is going to feel as a hot temperature. But if you increase the temperature beyond the 42 or 45 degrees Celsius, it will feel, it will give the pain sensation, not the hot sensation. Okay, so definitely whenever you increase the temperature beyond a level, it is going to cause the pain. So thermoreceptors also act, or the free nerve endings is going to catch that sensation, rather than it should go with the Krauss-Bird endings or your this Ruffini endings, right? So all of this fine touch, vibration and pressure, they are not going to relate with this free nerve endings. But yes, it is proven via the research that if you increase or give more than threshold value of this pressure temperature, definitely it is going to cause pain. It is going to cause pain, right? So you should be knowing about all those receptors, somatosensory receptors, where they are present and what their function is, right? Let's move on to the next question. An 8-year boy is hit in the head by baseline drive during a little league game, right? The father doctor rushes out on the field to do the neurological assessment, including use of a pen light reactivity of the pupil. So special senses का question है. So this is a question of the special senses. When light strike the eye, so light is striking the eye, which of the following normally increases? Which of the following normally increases, that they're asking. So when we say that from the dark, when we say in the dark, we do have something known as 11-cis retinal. 11-cis retinal. Okay, and that will be converted as soon as there will be light. There will be light. This will be converted into all trans retinal. All trans retinal. So and this happens with the help of the G protein couple receptor, and that G protein couple receptor is nothing but your transducin. This is nothing but your transducin. So answer over here is option A, the activity of transducin. Let's see the mechanism, how it is working, and then we'll come back to this question so as to get a particular idea why this is the answer and not the other options, right? So look over here. In the dark background, whatever is shown, that is happening in the dark condition, and whatever is it is shown over here, that is the patient in the patient's condition, and the question that is focused on, this is shown in the option B picture, right? So look over here, what is going to happen? There will be a G protein couple receptor. So this is a G protein couple receptor which is having that retinol molecule, Okay, as soon as the dark is there, in the dark what is going to happen, the levels of the cyclic GMP will be higher. The levels of the cyclic GMP will be higher, and once the cyclic GMP is higher, that is these brown molecules, when they are higher, look over here what is happening. They are attaching to the cationic channels. They are attaching to the cationic channel, mainly the sodium. Mainly the sodium, right? The calcium also enters, so that's why they're known as cationic channels, right? So they are going to keep this channel open. They're going to keep the channel open. So if the positively charged ion, that is these are cationic channels, so obviously it is going to allow the entry of positively charged ion, right? If it is coming inside, obviously the cell will be depolarized. Remember, the cell will be depolarized, and whenever the light falls on this receptors, what changes are going to occur? As I told you that this 11 cis will be converted into all trans. Okay, 11 cis form will be converted in the all trans. What is the difference? The difference is only morphological difference, not the chemical difference. Okay, so just a morphological difference. So that's why when we say that this conversion from the 11 cis to all trans occurs, one enzyme is going to help, that is the isomerase. The isomerase enzyme is going to work, and as soon as the light falls, this isomerase get active, and this light actually works on this isomerase that get active, and this will convert the 11 cis into all trans retinol, right? And once it is converted, what is going to happen? There will be activation of this G protein that is known as transducin. This is the transducin, this all trans retinol, this is the transducin. So this is G protein, so that's my, it is a heterotrimeric protein which should be having those alpha, beta and gamma subunits, right? The alpha will get separated, and this this is going to active. Once this alpha gets separated from this G protein coupled receptor, it go and activate the phosphodiesterase enzyme. It goes, this alpha molecule gets separated and it activates the phosphodiesterase. This phosphodiesterase will eat up this cyclic GMP, or you can say it is going to convert that cyclic GMP into 5' cyclic GMP. So that's why there will be no availability of cyclic GMP, and that's why this cationic channel will fail to open. Right, to open these channels you require these cyclic GMP molecules, and that's why the sodium will unable to come inside, right? And that's why this is going to cause hyperpolarization. So remember, this question are many a times asked in all the examination. Hyperpolarization, this is the exception, that whenever the light falls, the hyperpolarization occurs, and that's the, you can say, potential change, because of which we can see the things actually. And the cons work via hyperpolarization, rod works via the depolarization. So which of the following works or get activated when there is a hyperpolarization? Then your answer should be cones. Okay, these are the photoreceptors which are present in the eye. Okay, so the same thing is told over here. So whenever the visual pigments are present, that is rhodopsin and iodopsins are present, so 11 cis retinal is present, and that is going to get converted into all trans as soon as there is a light. As soon as there is a light falling and activating the isomerase enzyme, as soon as that happens, you can see that transducin which were inactivated before, that get activated, right? Over here they shown it with the yellow color thing, that activation, right? See over here in the dark condition it was inactivated, but over here it is activated, right? So activation of the transducin will lead to activation of this phosphodiesterase, the alpha subunit. So usually when we draw the G protein coupled receptor, first of all we draw it as 7 pass receptors. So 1 2 3 4 5 6 7, right? And over here there will be this trimeric protein, heterotrimeric protein, that is alpha, beta and gamma. This alpha gets separated, and when it gets separated, it is going to go and activate your phosphodiesterase protein, phosphodiesterase. And as the name suggests, phosphodiesterase, it is there, so it is going to convert the cyclic GMP into 5' GMP, which will fail to activate or keep the cationic channel. As I told you, over here it is shown that sodium, not only the sodium but also calcium, so cationic channel is the best option. If it is not there, then go for the sodium. So they will fail to keep this channel open. As you can see, to open this channel you require the cyclic GMP, right? So if the cyclic GMP is already converted into the 5' GMP, that means the cyclic GMP concentration is going to decrease, and which will fail to allow this cations inside the cell, and hyperpolarization will take place, and that's why this whole changes. That means we can see the light actually. Okay, so this is about all regarding this question. Let's come back to the option and see various options. The amount of transmitter released from the photoreceptor, that is not going to change, right? So photoreceptor not releasing anything, any transmitter. It's just that whatever is available, they are going to just break it down. Okay, concentration of all transretinal within the photoreceptors. So what they are asking is what is increasing. So photoreceptor may actually all trans will again convert into many forms, and it will divert into the photopigment. So this is also not the correct option. And when we talk about the photoreceptor, it contains all the rods also and the cones also. So this is not going to happen. The concentration of the calcium within the photoreceptors, obviously this is going to decrease. So all of them are going to decrease, just the activity of transducin will be more. Activity of transducin will be more, right? Let's move on to the question number 6. A research scholar in the AIIMS, New Delhi. Okay, he's working on some antiarrhythmic drug. He mainly targets the excitable tissue of the heart. That means he's targeting the nodal tissues, right? We do have two types of tissues. One is the cardiomyocyte, one is the nodal tissue or neural tissue, and nodal tissue they are excitable. Both are excitable, but let's see, nodal tissues are more excitable, right? He records the action potential graph throughout his experiment. On administrating a drug, he observed that slope of phase 0. So this is the thing which they wanted to ask over here. Slope of phase 0 is decreased and the duration of the action potential is increased. The drug is expected to act on which channels, they asked. So what over here we see is the something known as slow action potential. So as I told you, there are let's discuss that over here itself. There are two types of tissues in the heart, right? First is the nodal tissue and second is the cardiomyocyte. Now the nodal tissue contains a specific property that is known as autorhythmicity. Now, what is this autorhythmicity? Auto means by itself. Rhythmicity means to create or generate a rhythm. Okay, so it is containing a specific thing that is nothing but your specific three things which will cause to have this pacemaker potential. Now, what is that pacemaker potential? Let's learn one by one. Pacemaker potential. So what is this pacemaker potential? Remember, the pacemaker potential is the potential which will cause or which will lead this potential to reach to the threshold from the resting membrane potential value. So suppose this is the resting. When we talk about resting membrane potential, we're talking about the straight line. But remember, there are some tissues like the nodal tissue of the heart where there is non-stable you can say RMP is present. So what is the reason? First thing, we'll check on the graph also. First thing of this autorhythmicity or the pacemaker potential is funny sodium channels or the leaky sodium channels. These are the leaky sodium channels. So they do not need something to open something. They just leak out inside. Obviously, the concentration is more outside, and we know that the diffusion always occurs from high concentration to low concentration, right? So these are the leaky channels, and that is going to happen, that the sodium is going to leak inside the this nodal tissue. The second is there is something known as calcium T channels. That T denotes for the transient channels. So these are the channels which will open for very short duration of time whenever the RMP is going on. So in this particular potential, this calcium T channels are going to get open up, right? And third thing which happens in this non-stable or fluctuating RMP is that the closure of the decrease in the efflux of potassium channel. potassium channels, they start to close, or they get close, and that's why the efflux is going to decrease. So these are the three reasons why the RMP keeps going towards the threshold or keep going upward. So let's draw that one by one. So if suppose these three things happening, that means the sodium is coming inside the cell, right? So sodium influx occurring, positive channel influx, so positivity coming in. Also we opened up the calcium T channels, whatever it is, for shorter duration also it is enough to bring the enough calcium inside and to cause or make the nodal tissue to reach to the threshold. Okay, so this and decrease the potassium channel, that means potassium usually go out. If you decrease the efflux, that means it is also a positively charged ion, and that is accumulating inside the cell. So all of these changes will lead to the RMP to shift towards the positive side. So this slope is known as pacemaker potential. This is the pacemaker potential of the nodal tissue potential. Okay, now what happens is, as soon as, so usually it start to occur when it hits the -60, and it will happen till the -40 MV, which is known as firing level. This level is known as firing level. Now why this is known as firing level? Because the firing will start after this. So what firing? It reaches, that means it is nothing but the threshold, and after this the threshold value will reach, and then sudden as soon as this firing level will reach, that will make the opening of the not sodium, it will make the opening of the calcium channel. It will make the opening of the calcium channel. Which calcium channel? Calcium L channels. That means the long acting calcium channels are going to get open up, right? Long acting calcium channel will open up. It will reach a certain point at which the changes will occur. The changes I'll talk, and then the suddenly the repolarizations are. So what changes occurs, and which is this potential? This is known as spike potential. This is the maximum possibility, maximum positive value possible via this nodal tissues. In this, the calcium channels will close, calcium N channels will close, and the potassium channels will open. The potassium channel, as soon as they open, the potassium efflux will occur, and if the positively charged ion going outside and no more influx of the positive ions, what is going to happen? The cell will cause or go towards the RMP, or cell will cause the repolarization. That means it start returning to its RMP. It start returning to its RMP. Right, as soon as it hits the -60, again this cycle will continue, right? So remember over here what they're asking in the question is that about the phase 0, and phase 0, it is already shown over here that when we talk about fast action potential, then we have phase 1 and 2. Just the only change over here, that whenever it is going to reach first change is that this is the depolarization in the fast action potential. So if I have to draw the fast action potential, that means whenever this pacemaker potential will occur, it will go to the cardiomyocyte, and as soon as it goes to the cardiomyocyte, it will stimulate the cardiomyocyte. So cardiomyocyte ka RMP will be a straight line. As soon as the stimulus come from the pacemaker cells, what is going to happen? Suddenly the sodium channel will open up. First thing, the depolarization occurs because of the sodium influx. It occurs because of the sodium influx, right? And then it will reach to maximum possible positivity, and then the spike potential occurs. Over here the potassium channel will open up, the potassium start going outside, but soon after that, what is going to happen? The calcium channels also get open. So positive ion, one positive ion coming in, one positive ion going out. So this will lead to something known as plateau phase, something known as plateau phase, right? Once this plateau phase reaches, but this calcium channel will not open for longer time. They will start they will close after some time, right? And I'm not saying that potassium will close. Potassium is going outside continuously, just the calcium stop coming inside. So the repolarization will occur. So only you can see that all of these phases, that is this phase, this phase, this phase, it's going or leading the cell towards the, or trying to get back to its RMP. So these are given the numbers, such as phase number 1, this plateau is phase number 2, and this is phase number 3, and the RMP is said to be phase number 4. Then this is the only phase where the depolarization occurs or cell goes toward the positivity, and that is known as phase 0. Phase 0. If you cut down these two phases, that is phase number 1 and phase number 2, and you join, you can say, if you bring this third and fourth phase over here, then you are going to get this particular diagram or this particular graph which is shown over here, right? The slope, if you see, of the calcium, it is taking much more time, right, as compared to the sodium slope, right? So this action potential is known as slow action potential, and that action potential is known as fast action potential, because the depolarization, look over here, the depolarization is so quick, it's just a straight line, right? But the depolarization in the, this is happening in the cardiomyocyte. So cardiomyocyte के action potential को we call it as the fast action potential, and over here we are going to call this is taking time, so that's why we are going to say it as slow action potential, which is shown over here. So finally, what we are blocking at this phase, obviously this is slow action potential, and the depolarization occurs because of the calcium channel. And we know if we have to prevent this or prevent the arrhythmia, or we are working on this anti-arrhythmic drug, we have to block the calcium channel. So answer over here is option C. There is no role of potassium channel over here. Potassium channel role will come in phase 3, that is potassium efflux will occur over here, and over here we are causing depolarization, not hyperpolarization, so this is also a wrong option. Voltage gated sodium channel, as I told you, voltage gated sodium channel, they will open in the cardiomyocyte, not in the nodal tissues, right? So option C is the answer over here. Let's move on to the next question. A 68-year-old woman with the hematemesis has heartburn and stomach pain. So GI question again. And endoscopy shows inflammation involving the gastric body and antrum, as well as small gastric ulcers. So okay, we do have small gastric ulcers. The biopsies were positive for H. pylori. H. pylori damages the gastric mucosa primarily by increasing the mucosal levels of which of the following? Very easy. Once I'll show you a diagram, you'll get the answer in a second, in a millisecond, you can say. Okay, so look in this diagram, so beautifully shown over here, that what is happening to our gastric epithelial cells. Now the thing is, the question teacher used to ask us in the, when we were child, right? So they used to ask us that we can eat chicken, we can eat the non-veg things, right? We can eat those things and we can digest those things, but how is it possible that our own body does not digest, or that acid which is present, that is digesting that non-veg, right? That means that is contain the protein, carbohydrates and the lipids, and we also having the protein, our body also made up of protein, carbohydrates and lipid. How is that possible that we able to digest the meal, non-veg meal, but not, we are not, our body understand that this is my body part, and it is unable to digest our own body part or our own stomach, which is made up of with the same building blocks, that is protein mainly, and some fat, some carbohydrates, right? So let's see what is that. The layer that is preventing us from digesting our own cell is known as the barrier, the bicarbonate barrier, or gastric barrier, or gastric mucosal barrier. There is a barrier in the acid in between the HCl and the epithelial cells of the gastric, you can say, organ. So epithelial cells, in those between the gastric epithelial cells and the HCl, we do have barrier, and that is known as the mucosal barrier, right? And this H. pylori able to see the acid, it is a primary defensive mechanism to protect us from the bacteria and the viruses, whichever whatever the microorganisms are there inside the food. Okay, so but this bacteria can survive in the pH. It's a burning high pH. How much is the pH of the stomach? 1.2 to 2. 1.2 to 2. Such high hydrogen concentration, all of the microorganism will die in such high pH. You can say such low pH, that is such high acidity. Okay, acidic pH. such high acidic pH. But how is that possible that this bacteria is able to, Helicobacter pylori, it is able to survive in such a high acidic pH, okay, or such low pH? Two different things I'm saying over here, okay. So what it does is it is having a golden, you can say the enzyme or miraculous enzyme that is known as urease. That is known as urease. See over here what happens. As soon as it enters in the mucosal barrier, first of all, it goes towards the epithelial cell. And how it is possible that they are able to survive? First of all, see in this diagram that they are having this ureases. Now, this urea, what it is doing is, it is breaking down the urea and water into carbon dioxide and ammonia. So what this NH3 is doing is that it is neutralizing the gastric acid, and it is making the alkaline wall around this bacteria. So it is having that protection which is shown in the movies, usually the round protection against all those heroes. So yeah, so such that this ammonia is actually, NH3 is actually helping and forming that barrier, alkalinity around this bacteria. And this is possible because of this urease which is present on this or in this H. pylori, right? So but as soon as it's okay that he's living in that gastric acid, that is it is okay until and unless he's living over there. But what happens is, after that they start moving towards the gastric epithelial cell for the nutrition. Okay, they start moving towards that. As soon as many the H. pylori comes near this gastric epithelial cells, what happens is they are having those urease activity going on continuously. They are forming that NH3 continuously, which is making the alkaline surrounding around them. Okay, but when they come near this gastric epithelial cell, this alkaline surrounding is not only around this bacteria but also around this gastric epithelial cells. Towards which these bacteria are there, okay, or these bacteria are taking the nutrition form. Now, these gastric epithelial cells, they do have pH sensors also. So they sense the pH, and then they give the gastrin release, right? So pH sensors are there. Now, there is a trick in this, that the pH that they are sensing, they think, obviously they cannot see, the epithelial cells cannot see, so they think that this is the gastric pH, right? But they do not know that this pH is made by, this alkalinity is made by this ammonium which is created via this H. pylori. They do not know that. They sense the pH, that the pH is high or the pH is alkaline, right? They sense as if the pH is alkaline, and they start stimulating the G cells. They start stimulating the G cells. G cells go and release the gastrin, and the gastrin is going to stimulate the parietal cells. That gastrin is going to go and stimulate the parietal cells. As soon as this parietal cells is secreted, that is going to release more and more and more and more HCl. Now, there is always should be a balance between this bicarbonate layer, that is the barrier, and the HCl that is going to be created. If this continues for a prolonged time, what is going to happen? This acid secretion will start exceeding this barrier, you can say value or barrier level. What is going to happen after that? There is a disbalance between these two, and the acidic content is dominating in the stomach now. Now what will happen due to this H plus ion, such a high concentration of H plus, the barrier will not be able to manage with that, and since the barrier will start breaking away, this barrier will start breaking away, the mucosal barrier will start breaking away, right? And this also, this is containing, this bacteria also contains mucinase. This also contains mucinase with the urease. They also break down this mucin, that is the mucosal layer which is present in the stomach. So both of these things are going to increase. Mucinase is going to break down this barrier. The H plus concentration is increasing inside the stomach. Both are going to lead to the damage to the gastric epithelial cells. Okay, so that's how the mechanism, once the bacteria enter, that H pylori enter inside the stomach, this mechanism will go on, and then the gastric epithelial cells get damaged, and because of that this burning sensations will be there, and the gastric acid secretion will be continuously increasing, and unless and until the patient get the treatment, right? So yes, this is going to cause the inflammation. If it is not stopped at that level also, it is going to lead to mucosal cell death, right? Mucosal, not only mucosal, but the gastric epithelial also, the scarring will be present. Okay, so what is the answer over here? The H pylori, they already gave the hint. H pylori, what it is going to increase? It is going to increase the ammonium. So answer over here is option A. Answer over here is option A. Definitely it is have nothing to do with the bile salt. Yes, the gastrin is increased, but that is not going to cause that damage to the gastric mucosa directly, right? NSAID. So she's not having any history of NSAID. So yeah, that is not possible via the H. pylori. So answer of the question 7 is option A. Let's move on to the next question. Question number 8. A 55-year-old man comes to his primary care clinician complaining of erectile dysfunction. He is given a prescription for Viagra, and on follow-up reports that his ability to sustain the erection has been improved. Okay, so drug worked. So yeah, does the miracle markedly by the treatment. Okay, the action of the vasoactive mediator will act through which of the secondary messenger? So first of all, we should know what is this Viagra and how this is acting. So Viagra is causing the vasodilation, and this vasodilation is happening with the help of the vasoactive mediator. Now you'll ask me which of this vasoactive mediator they're talking about. They're talking about the nitric oxide, NO. They're talking about the NO. Okay, so this NO will act through the cyclic GMP. This is going to act through the cyclic GMP. So again, this is going to act through the GPCR protein, right? So say this is the cell membrane, this is the cell membrane, and suppose over here somewhere you do have that 1 2 3 4 5 6 7. Okay, so this is the G protein, let's say. So this NO will act on this, NO will act on this, and what is going to happen is it is going to activate this G protein couple receptor. This is going to activate this G protein couple receptor, or we can say GPCR protein. Okay, GPCR. Okay, now again this alpha beta gamma, alpha gets separated, right? And as soon as it gets separated, the GTP will be bound to it. GTP will bound to it, right? Usually the GDP, as soon as this NO binds to it, what change occurs so that this gets separated? That I'm telling you, that usually the GDP is bound to this heterotrimeric protein. But this GDP, as soon as this NO will come, this GDP will get away, and the GTP will be bound to this heterotrimeric protein, and that's how the alpha, you can say the subunit, gets separated and get activated. But this alpha also have GTPase activity. This alpha subunit, it contains something known as GTPase activity. So I told you AS means it is going to break down that thing, right? So GTP over here is going to convert into GDP plus the inorganic phosphate plus the inorganic phosphate. Now, what is going to happen over there? In the inner layer of the cell membrane, you do have something known as GC. Now, what is this GC? This is known as guanylyl cyclase. Guanylyl cyclase. This is present in the inner. So you do have inner cell membrane and outer cell membrane. We know that this is the bilayer, right? In the inner membrane, you do have this GC, that is guanylyl cyclase. Now, this guanylyl cyclase, what it is going to do? It is going to break down whatever GTP available into cyclic GMP. cyclic GMP. This alpha, once it is activated, it is going to activate this GC, right? First of all, NO activated this GPCR. This GPCR activity leads to the binding of GTP to the alpha 1, and that gets separated from beta gamma unit, and that get activated. Once it get activated, it will also activate the GC over here. As soon as this GC get activated, what is going to happen? It is going to convert this GTP into the cyclic GMP. That is going to convert this into cyclic GMP. So what do you think? What is going to happen when there is a release of more and more NO? What is going to happen to the concentration of cyclic GMP? The cyclic GMP is going to increase. It is going to increase, and that is going to lead to activation of the protein kinase G. Protein kinase G, and that will cause whatever cellular effects are there. So this is the basic fundamental activity what is going to happen in the cyclic GMP pathway. We say GMP, that means over here this is the secondary messenger. Primary messenger always is the hormone or the substance which activating the GPCR protein. Okay, so the primary messenger over here, the primary messenger is the NO, which is the vasoactive substance that they are talking about over here, and the secondary messengers which activate the kinases inside the cell and cause this cellular effect. So vasodilation will occur at the level of the penis, right? So the cyclic GMP, that happens because of this secondary messenger increases inside that localized area. So over here the answer is cyclic GMP. The cyclic AMP will also act in a similar manner. It also acts somewhat in the similar manner. So I hope this will help, this chart will help you out to make out this differences in between these two signals. That means hormones, neurotransmitters, or vasoactive substance, whatever it is going to come, that is going to activate G protein, right? They are going to activate the heterotrimeric protein, and ultimately the breaking, if you're talking about cyclic AMP, you should talk in terms of ATP. If you're talking about cyclic GMP, we should talk in terms of GTP. They are going to activate the G kinase or A kinase, that is protein kinase A or protein kinase G, and they are going to have all those biological responses. Once the response is over, the cyclic GMP should not stay for long, right? So they are broken down ultimately via phosphodiesterase as soon as the effect is over. Right? So answer over here is option B, cyclic GMP. Let's move on to the next question. Question number 9. A 32-year-old male who is being treated for acute leukemia develops oliguria. His serum creatinine levels are 2.7 milligram per liter. Renal biopsy reveals multiple uric acid crystals, okay, obstructing renal tubular lumen, the principal site of uric acid precipitation. Okay. So what is happening over here? The uric acid crystals, they are accumulating at some area, and that is causing the obstruction. So you can see over here in this question, the hints are there, multiple uric acid crystals, and that's why he is having oliguria. That means they're causing the obstruction. Simple way, they're asking what is the site where this is going to happen. Remember, one thing just remember about this uric acid, that uric acid usually it is soluble at the physiological pH. So when we talk in terms of uric acid, this uric acid or urate, we say that it is soluble. It's very much soluble at physiological pH. But over here they are writing that it is causing crystal. I'll come to that, don't worry. Okay, so what happens is, I'm talking about physiological pH. But what if the pH goes down? If the pH goes down, that means if there is a low pH, the uric acid start getting crystallizing, or that will crystallizes. The uric acid crystallizes, or the crystallization will start in this. Okay, now we should just identify, we have to identify that where this crystallization is possible, so that the precipitation is occurring. That means crystallization or precipitation is starting. We just have to identify where the low pH is present, So remember, the lowest pH in the whole of the nephron, lowest pH, or you can say that along the nephron. So lowest pH, when we talk in terms of nephron, along the nephron, it is found in the distal tubule. It is found in the DT. That means the DT has two parts, the distal collecting tubule, convoluted tubule, or the collecting duct. Distal convoluted tubule or the collecting duct. Now, out of all these segments, the collecting duct is having the highest pH. Why? Because there is so much of concentration of the urine, right? So low, not the highest acidity, you can say, or the lowest pH, it is present in the collecting duct. And that's where, if there is a lowest pH, that is going to cause the crystallization. And once the crystallization starts, obviously what is going to happen? The uric acid start getting precipitated. So precipitation will start over here, right? So basically we got the answer that lowest pH you have to identify first, and then you have to talk in terms of all of this, right? So we know that proximal tubule, due to high solute concentration, this is not possible. Over there the isotonicity is there and water is pretty much there, so precipitation, there is no chances of that. Proximal tubule, again it is talking about proximal tubule, it is having pretty much similar isotonicity as well as the pH is almost similar. So impair uric acid transport. No, there is uric acid transport is not happening over there. That is happening in the loop of Henle and the you can say the collecting duct, that too in terms of urea, right? Loop of Henle, again it is not because of the hyposmolarity, and it is having also the isotonic fluid. So this is also not true. We know that collecting ducts maybe do have low pH, and where there is precipitation is going to start, right? So answer over here is option D. Let's move on to the last but not the least question, important regarding the respiratory system. Again the graph is given. The graph below represents the relationship between the chest, lung and both together with respect to the transmural pressure. Now whenever we talk in terms of transmural pressure, so the trans pressures are there and intra pressures or inter pressures are there, right? I divide it into, whenever I teach, I divide it into either trans or intra. So intra-alveolar, intra-pleural, intrathoracic, right? So we talk in terms of one pressure when we talk in terms of the intra types of pressure, right? But when we talk in terms of trans pressure, so there are intra pressures and trans pressure. So trans pressure, when we talk in terms of trans pressure, we always talk in terms of differences in the two compartments. So difference in the two, you can say, compartments. Okay, and usually whenever we talk in terms of differences in two compartments, one thing we have to do is, we have to, first thing, whenever we talk about transmural pressures in the respiratory system, see, we do have lungs. We do have lungs like this, right? I'm just drawing a simplified version of the lung. And then we do have pleura over here. I'm not drawing both of the pleuras. One is connected to the viscera, one is connected to the thorax, and the second and outside which we are going to have the chest cavity. We are going to have the chest cavity like this. Okay, and then we are going to have a diaphragm over here. Okay, so we are going to have this thorax, and in this thorax, so when we talk in terms of let's say chest pressure, okay, mural pressure, again the chest wall. So what we are going to talk about, first we are going to talk about the atmospheric pressure and this chest pressure. Okay, so this let's write not the chest so long. So the okay, give me a time. So let's draw like this. Okay, so this is the condition. This is the condition. So it is one layer which will be attached to the chest wall. So this is the chest wall. Okay, so adjacent two things are this and this, that is atmosphere and pleural layer. Atmosphere and pleural layer. When we talk about pleural pressure, transpulmonary pressure, then what we are going to talk about, this intra-alveolar. So over here the alveoli will be there. So intra-alveolar pressure and intra-pleural pressure. So two things we are going to talk about. And when we are going to talk about both, then we will see in the diagram that how we are going to change them. So first of all, when this diagram is given, you have to identify that which one is which. Okay, so this is a typical Bible wala diagram. That is, I'm not talking about the Bible which we use for spiritual thing. The Bible of the physiology that I'm talking about, the Genome. Okay, so this pressure over here which is shown is the chest wall pressure. Okay, the transmural pressure along the chest wall, or you can say that compliance along the chest wall. So this is a typical pressure versus volume graph, right? So you can say pressure versus volume graph. So this is nothing but the compliance, right? And this over here, the another black which is given, so the B1 over here, that is nothing but your the pressure, transmural pressure along the lung, or you can say compliance of the lung. Okay, compliance of the lung or transmural pressure along the lung. And the middle one which is shown, that is the integrated over here, that is the combined pressure. Okay, so that is the combined pressure which is shown over here. Okay, so when we talk, I just now told you that when you talk in terms of this chest wall pressure, so what you are going to do is, first thing that you should know, that you are going to identify which are the layers, right? Adjacent layers, and the second thing is application of the formula. And what is that formula? N minus out, whatever inner layer is there, inner layer pressure minus outer layer pressure, inner layer pressure minus outer layer pressure. Easy two things you have to do whenever you talk about the trans pressure, any trans pressure, you will never make the mistake if you apply these two things, right? So let's talk about the let's talk here only. So if we are talking about the chest wall, if you're talking about the chest wall, so what is the inner layer of this chest wall? Adjacent inside is the pleural layer. So when I'm talking about the chest wall, let's write PW, right? When I'm talking about the chest wall, so how I'm going to write the formula? I identified the adjacent layer, that is the atmosphere, and the pleural. Inside is the pleural. So I'll write the formula as IPP minus atmospheric pressure. Minus atmospheric pressure. Easy thing, right? Then if we talk about the lungs, let's talk about this over here, transpulmonary. That means along the lung, the parenchymal tissues, what will be the pressure differences? What will be the pressure differences? So what are the two adjacent layer? The first adjacent layer over here is, yes please, the first adjacent inside layer is IAP. Over here there will be lots of alveoli, right? So intra-alveolar pressure minus IPP, intra-alveolar pressure minus IPP. So pressure along the lung, intra-alveolar pressure minus IPP, right? So this is the formula for these two things, right? When I talk about the combined one, that is the transthoracic pressure, right? That will be when I'm going to write the combined pressure, so along the thorax. If I'm talking not along the chest wall, not along the chest wall, I'm talking about whole of the thorax. Then the inside, innermost layer is IAP, outermost layer is atmospheric. So if you take transthoracic pressure, then transthoracic pressure, that is combined pressure of these two, that will be, the formula will be IAP minus atmospheric pressure. Simple, right? Very simple. Okay, so identify the adjacent layers and just in minus out, apply this formula. You're never going to make a mistake. You're never going to make a mistake. So what they're asking, now whenever you do this formula, you apply this formula, usually the intra-alveolar pressure. So if, let's go back and discuss in 2 minutes. Nothing bad will happen in 2 minutes. This is the last question. We have to justify this question, right? So chest wall, intrapleural pressure is usually negative. So negative minus positive, that value will be negative. That value will start with the negative. When you start with the intra-alveolar pressure, that depends on whether it is inspiration or expiration. So but intrapleural pressure will be always negative. It will be always negative, and it will be more than this intra-alveolar pressure. So it comes out to be, usually it comes out to be positive. Usually it comes out to be positive. And integration, it will come in middle itself. So that is the transthoracic pressure. So the one pressure which start with the positivity, that you can say positive point, that you can say this is the PL, that is the lung compliance along the lung, right? Or the pulmonary, intrapulmonary pressure, the transpulmonary pressure. Why? Because the IAP is less negative as compared to IPP. IPP is always negative. So if you subtract something negative, so IAP, whatever the value will be there, so X minus Y, let's say the Y is denoting the IPP, which is usually negative. So minus that will become plus, right? So that's why it starts from the positive. It starts from the positive. So look over here, how to identify this? I do not know, right? So just now I told that PL will be positive, right? So this must be over here. You can see that this is the zero value. This is the zero value. Below the zero value, obviously the negative values will be there. Negative values will be there. That means this is the PW. This is the PW, and that is transmural pressure along the chest wall, and this is the transmural pressure along the pleura, let's say, or lung, right? Compliance of the lung or transmural pressure along the side lung only. Otherwise PP will be confusing, right? Integrated, they themselves gave, or if you cannot identify which is the integrated one, it is easiest one in between, whichever is going to come, that is the integrated. So that's how you can identify. So let's find out which combination is showing this. So A is our PW, right? A is our chest wall ka this value, right? A is our chest wall ka value. So let's see, lung. So this is not the answer. First of all, 50% is over. So either the answer is A or C, right? Then the B curve is PL. Over here also lung, and here also curve for the lung. So the third thing, X, it is a functional residual capacity or the residual volume. Remember, when this point over here, this point is known as relaxation volume, not residual volume. It is known as relaxation volume. Now what is this relaxation volume, and why it is known as relaxation volume? This is known as a relaxation volume because, see over here, that these two values, that is the difference or these pressures will be equal and opposite. These pressures will be equal and opposite. So that's why lung will be relaxing at that time, right? It is at its relaxing you can say stage or relaxing phase, right? And this is nothing but your FRC. This value is nothing but your FRC at the functional residual capacity. That is nothing but your expiratory reserve volume plus the residual volume. So not only the residual volume, in the FRC we also add ERV plus RV, that is the expiratory reserve volume as well as the residual volume, right? So this is the relaxing volume at which the lungs will not do any work. That means lungs are not using the ATPs. So that's why this volume is known as relaxation volume. Remember, this is also asked that they will give the point over here like point X and identify this X. So this is always and always a relaxation volume or your FRC or ERV plus RV. So let's see. A is saying that it is the residual volume. No, residual volume plus ERV should be there. That is the functional residual capacity. So answer of this question over here is option C. And with this question, we completed the physiology integrated clinical questions, right? I hope you like the session. If you like the session, please let me know in the comments. Please let me know, our family of DBMCI, that you love the session. If you want any such sessions, we are open for the suggestions, right? I hope you like the session. That's all from my side. See you next time. Bye bye.